patient. Last 2 days is from Raichur, Karnataka.
Hypertension is a growing epidemic in the
Can you
world now.
just increase your voice, the sound little bit low?
Okay, sir. You can see in this graph is showing the years of life lost to the comorbid conditions. Compared to the direct damage done by smoking or cancer, high blood pressure is direct contributor to the years of life lost. So in the projected over the next 20 years, hypertension is going to rank one among all these indicators. It is going, if you see in the world population, more than 25% of the population are having adults have hypertension. One second. So if you can see this cascade diagram, the left is on the woman and right is for the men. Out of this, we can see those only 40% are still not diagnosed in women, and more than 50% are not diagnosed in men. So we can see in the steel bars, out of the women diagnosed, 59% of women diagnosed, less than 25% are controlled. The same way, we see in the group of men with teal colored bars, 49% of those diagnosed, and out of them only 18% are controlled. So this graph is showing the control of hypertension over the past few years, which shows the graph is going and has an uptrend for till 2009. But after that, it has taken a negative turn and going towards the wrong direction. So that implies only fewer than 50% have control of hypertension. So why we need to control this hypertension? So if you see in this graph, done by two meta-analysis, if a sustained pressure drop of 5 millimeters of mercury, it is reducing the risk of major cardiovascular diseases, stroke, heart failure, ischemic heart diseases around 5%. If this drop is sustained to more than 5 millimeters, that is 10 millimeters of mercury, the events are reduced much more as compared with the 5 millimeter drop of mercury in blood pressure. So how we diagnose the hypertension? JNC guidelines have been 2003, now JNC 8 has come, and American Association of Cardiology from 2017, the normal blood pressure is less than 120 upon 80 millimeters of mercury. Those with 120 to 129 systolic and less than 80 millimeters of mercury diastolic are considered as pre-hypertension in JNC 7 guidelines. However, in ACC guidelines, they have been termed as elevated blood pressure. Similarly, those with 130 to 139 millimeters of systolic upon 80 by 80 to 89 millimeters of mercury were also considered as pre-hypertension JNC guidelines 8, but they were termed as stage 1 hypertension in ACC guidelines 2017. Similarly, stage 1 hypertension, which was JNC guideline 1, they have been upgraded in ACC guidelines 2017 with 140 to 169 millimeters of mercury and diastole being 90 to 99 millimeters of mercury. More than 160 upon 100 were staged as stage 2 hypertension. So in this, the individual systolic and diastolic blood pressure in two categories were designated a higher blood pressure category compared to JNC 7. So the hypertension and peripheral artery diseases, there are two studies, the cardiovascular research using linked bespoke studies and electronic health records. It showed the association between systolic blood pressure, diastolic blood pressure, and 12 cardiovascular diseases in 1.25 million patients. And they found out that the elevated diastolic blood pressure has a greater effect on the abdominal aortic aneurysms. Increased systolic blood pressure was the strongest predictor for intracerebral and subarachnoid hemorrhage, myocardial infarction, angina, and peripheral artery diseases. A meta-analysis from 2019 showed that the relative risk of developing an abdominal aortic aneurysm by 66%, and this increases by 14% and 28% for every 20 millimeters and 10 millimeters of mercury increase in systolic blood pressure and diastolic blood pressure. So on the continuation of it, the Framingham Heart Study, which was a comprehensive study over the past 38 years, they found the association between peripheral artery disease. They considered intermittent claudication as peripheral artery disease. They found out that with the increase in systolic blood pressure and diastolic blood pressure, it increased the risk of peripheral artery disease. And the odds ratio was approximately 2.2% when symptomatic or patients. Another study, National Health and Nutrition Examination Survey, they also took into consideration intermittent claudication as peripheral artery disease. They found that hypertension, which is untreated, or those treated but still uncontrolled despite of treatment, they have an increased risk of peripheral artery diseases. Studies which included ABPI, like NHN's cardiovascular heart study, the cardiovascular heart study found an inverse relationship between the hypertension and the ankle brachial pressure index. So the increase in hypertension is associated with a decrease in ABPI. So the investigators controlled the confounders, but still they found out that the relation still exists between systolic blood pressure, but it does not exist for diastolic blood pressure. And the study, the Rotterdam study, they used the ankle brachial pressure index of less than 0.9. Systolic blood pressure, but not diastolic blood pressure, was strongly associated with peripheral artery diseases. So why we need to control and to what level we need to control this hypertension? So one trial, we have a SPRINT study, which is the systolic blood pressure intervention trial, which included 9,361 patients, which included with hypertension and cardiovascular disease risk patients, but without diabetes. They categorized into two groups. One is with the intensive monitoring and another with the standard treatment. Intensive monitoring with less than 120 millimeters of mercury, and standard treatment with less than 140 millimeters of mercury. The primary outcomes be the myocardial infarction, acute coronary syndromes, heart failure, and deaths because of cardiovascular causes. They notably and surprisingly stopped the trial and because of the early and low fatality because of cardiac or non-cardiac causes in those patients with less than 120 millimeters of mercury. In this chart, you can see less than 5.2%, and the death from any cause being reduced to 3.3%. So another trial is the United Kingdom TBS trial, which showed a tight BP control in patient with hypertension and diabetes. This control, if a patient is having a tight control of blood pressure, it reduces the risk of deaths related to diabetes and the onset of diabetes related complications like diabetic retinopathy and reduced visual acuity. One more trial is ACCORD trial, which is Action for Control Cardiovascular Risk in Diabetes, which included 4,733 patients of diabetic patients with or without intensive glucose monitoring. And they found no reduction in composite of non-fatal MI, stroke, death from cardiovascular disease. However, it did prove that targeting a blood pressure less than 120 had a definitely improved in risk of stroke and non-fatal MI. So how to measure the blood pressure? First, in our office, the patient should have been resting for 3 to 5 minutes before taking their blood pressure. Patient's bladder should be emptied before taking blood pressure. No alcohol, caffeine, or caffeine-contained drinks or smoking at least 30 minutes before taking blood pressure. Arm should be supported at the level of the heart. Appropriate cuffs and size should be used when taking blood pressure readings. Blood pressure should be taken on bare skin. Patient should sit in an upright position with the back supported. Patient should not sit with legs crossed. Patient should be quiet, and both the doctor and the patient should not, it's better not to speak to each other at the time, and ensure that the patient is not cold because of the room temperature. So the indications of ambulatory blood pressure monitoring. Ambulatory blood pressure monitoring is a technique which can be used to verify the diagnosis of hypertension in certain situations. It is used when evaluation of desperate office and home BP readings, elevated office readings and white coat hypertension, or a low or normal office readings with a target organ damage. Assessment of borderline or labile hypertension, assessment of efficacy of therapy, evaluation of episodic hypertension or orthostatic hypertension, clinical pharmacological studies of new drugs or research. In a systematic review of US Preventive Services for Task Force in 2015, they found out that ambulatory blood pressure is better predicted cardiovascular events than in-office blood pressure monitoring. So how to measure it? It comes with a portable device, and the patient is monitored, and it's automated and programmed to occur every 15 to 30 minutes intervals over a 24-hour period. In 2017, ACC guidelines will quantify the definition of hypertension with ambulatory monitoring with one of these three criteria. The patient should have a 24-hour mean of 125 upon 75 millimeters of mercury, awake mean 130 upon 80 millimeters of mercury, and sleep mean 110 upon 65 millimeters of mercury. So if you see the relation between hypertension and atherosclerosis, so any like hypertension, smoking, diabetes mellitus, or any hyperlipidemic states, they lead to accumulation of advanced glycosylation end products. These advanced glycosylation end products leads to increased reactive oxygen species and oxidized LDL. This oxidized LDL is retained in the cell and it leads to endothelial dysfunction and impairs the release of nitric oxide. And endothelin 1, it binds to endothelin ETB receptors and it really helps in the release of cell adhesion molecules like ICAM1 and BCAM1. It also binds to macrophages, releasing colony stimulating factors and monocyte chemoattractant 1. It also activates ETA receptors, which helps in with proliferates vascular smooth muscle cells. Here we can see that tetrahydrobiopterin, they have three sources for tetrahydrobiopterin in the cell. One is GTP, sepapterin, and quinoids. So when this tetrahydrobiopterin is itself anti-atherogenic, when these levels are reduced, when there's uncoupling of endothelial derived nitric oxide synthase, this leads to reduction in nitric oxide. This reduction in nitric oxide state itself, it creates a state of endothelial dysfunction. You see the pathophysiology of hypertension, blood pressure is the cardiac output into peripheral vascular resistance. So the hypertension is increased blood pressure, increased cardiac output, peripheral resistance is increased, peripheral resistance or vascular constriction. So the patient has renal sodium retention, either because of excess intake or some genetic alterations. They have an increased fluid volume overload, which increases the preload and which indirectly increases the cardiac output. And the cardiac output can also be increased by the contractility in the heart rate. Only two major I have taken here. One is renin-angiotensin system, which through angiotensin 2 causes vasoconstriction, and sympathetic nervous system, which also causes vasoconstriction, which ultimately leads to increase in peripheral resistance. In this renin-angiotensin system, when the pressure drop is sensed by the kidney, it releases renin. This renin acts upon the angiotensinogen from the liver to angiotensin 1. Here acts the angiotensin converting enzyme from the lung, which converts angiotensin 1 to angiotensin 2. And angiotensin 2 is a potent vasoconstrictor. It also acts on the adrenal gland, releasing aldosterone, which again leads to fluid retention and volume overload. And this is the same endothelial dysfunction. The decrease in nitric oxide itself creates a pro-thrombotic, pro-inflammatory, and the state which initiates progression of atherothrombotic diseases. So cause of hypertension may be primary or essential hypertension, which are developed over time. Main causes being genetic, smoking, obesity, high intakes of sodium, less intake of potassium, high alcohol consumption, stress, lack of exercise, aging. And secondary hypertension causes being obstructive sleep apnea, in which the patient will have a resistant hypertension with loss of normal nocturnal blood pressure fall. The patient will have obesity, snoring, and hypersomnolence. Heart defect like coarctation of aorta, usually the patient is a young patient with hypertension, with desperate blood pressures between both upper limbs, and absent femoral pulses. Continuous murmur may be present over the chest or the abdominal wall. Kidneys may be atherosclerotic or fibromuscular dysplasia, where there's abrupt onset of hypertension. The patient usually have a flash pulmonary edemas, abdominal vascular buoys may be heard. Medication history we should take properly from the patient, as they might not be telling us the history. Most people will take over-the-counter Brufens, and some ladies may be taking oral contraceptive pills, which they might not disclose us. Adrenal and thyroid gland condition like hyperthyroidism, hypothyroidism, Cushing's, and primary aldosteronism, they also causes of secondary hypertension. So there are certain non-pharmacological interventions which are proved for the treatment of hypertension. Out of this, a DASH diet containing rich in fruits, vegetables, whole grains, and low fatty diets with reduced saturated contents, they have a maximum drop of reduced blood pressure compared to other more or less even 5 millimeters of mercury drop. So weight loss, healthy diet, reduced intake of sodium, enhanced dietary intake of potassium, physical activities, 90 to 150 minutes per week, or isometric resistance, dynamic resistance, and moderate consumption of alcohol, they all have found to be reduced, help in reduce reduction of blood pressure. So the general principles in the treatment being the primary benefit from antihypertensive therapy is more associated with the degree of improvement in the blood pressure and not associated with the use of any one specific drug. Therefore, selection of initial monotherapy is largely driven by the side effect profile and the patient's preference. If systolic blood pressure is more than 20 millimeters of mercury above the target, or diastolic blood pressure more than 10 millimeters of mercury above the target, one should consider that monotherapy is not sufficient. So what to do if initial monotherapy is not sufficient? In general, either switching to a different monotherapy or adding a second drug is more effective in controlling hypertension than escalating doses of the first drug. The risk of side effects may be increased by either adding a second drug or escalating doses of the first drug depending upon the patient's situation and the patient. Adding a second drug may result in decreased compliance as patient might not be feeling good enough to take more pills. There's a high chance of loss of compliance, hence a combination pill is better used. If you see the antihypertensive drugs, two main systems we have taken here. One is the renin-angiotensin system and another is the sympathetic system. The renin-angiotensin system, if you see in this first chart, when the pressure, the mechanism is same, the renal perfusion drop is the kidneys release renin, which acts to control convert angiotensin 1 and again angiotensin 2 is systemic vascular resistance. And aldosterone, angiotensin 2 also acts on steroid precursors, which activates aldosterone and increase in sodium and reabsorption. So there are 5 classes of drugs which are acting here. Diuretics, which act on the renal sodium and chloride reabsorption. So that is the distal convoluted tubule diuretics. It blocks the sodium chloride input. It's more effective in patients with low renal levels, like in blacks. The ALL-HAT trial, which is antihypertensive and lipid lowering treatment to prevent heart attack trial, which showed that thiazide diuretics are much better because of their low cost and they coupled with prevention of heart failure and stroke. Hence, the investigators concluded that especially long-acting thiazide diuretics, especially chlorthalidone, to be the first-line drug in the treatment of hypertension. They also help in the decreased calcium excretion and prevent renal stone and osteoporosis. However, they have side effects like electrolyte imbalance and decreased potassium, dose-dependent potassium. If you see the angiotensin receptor blockers, they act at aldosterone level at this level. They work by inhibiting the angiotensin 1 receptor. It has similar indications to the ACE inhibitors. There are 2 trials here. One is a losartan intervention for endpoint life trial, which included a patient with hypertension and left ventricular hypertrophy with losartan and divided into losartan and atenolol. They found that lower cardiovascular morbidity and mortality in patients using losartan. One is an on-target trial, which studied the patient into telmisartan and ramipral. They found equivalent cardiovascular outcomes and lower risk of angioedema, those patients. And the combination, however, with ACE inhibitors and angiotensin receptor blockers, they found to be have increased adverse events with no added benefits. Hence, it's better not to add ACE inhibitors and angiotensin receptor blockers. They are first-line drugs in CKD patients, proteinuria patients, and diabetes mellitus patients. However, because of their congenital malformation and they are contraindicated during pregnancy. Another class of drugs is the ACE inhibitors. They block the AT1 to angiotensin 2. They lower the BP and they improve the endothelial dysfunction and vascular remodeling. Multiple randomized controlled trials, they prove the superiority in peripheral arterial disease plus hypertension. One trial I would like to mention is HOPE trial, which included patients with atherosclerotic vascular disease and diabetic mellitus. Those patients with the ramipral, they found out that they increased myocardial infarction, stroke, and all-cause mortality versus placebo patients. However, ACE inhibitors have side effects like dry cough, angioedema. They do cause certain amount of cardiovascular and CNS malformation. Hence, they have to be used contraindicated in pregnancy. One more are the direct renin inhibitors, allocerenin, which is used as a direct renin inhibitor. which acts at the first step of the renal angiotensin system. It has got a long-acting and equal efficacy to ACE inhibitors and angiotensin receptor blockers. There's much better in combo, but an altitude trial was done which showed that type 2 diabetes mellitus with renal and cardiovascular endpoint, they found out that high adverse events with direct inhibitors. Hence, because the side effect profile, it's not commonly used. One more thing is that drugs acting at the central nervous system, beta blockers, which acts at the beta 1 receptors, which increases heart rate and myocardial contractility. Uh, Before they were considered as first line drugs because of the alpha blocking properties as well. A meta-analysis have shown that they're inferior for preventing cardiovascular diseases in patients without prior ischemic heart diseases. They're indicated in patients with coronary artery disease and heart failure. However, because of the side effect profile, they should be used in caution with patients with bronchial asthma, COPD, and cardiac conduction abnormalities. Calcium channel blockers, they have two classes of drugs. They work by interacting with the L-type calcium voltage-gated plasma membrane calcium channels, and they disrupt the calcium transport. We have dihydropyridines and non-dihydropyridine groups. The examples being amlodipine and dihydropyridine being diltiazem and verapamil. Clonidine and methyl dopa, they are centrally acting drugs. Although they are effective, they are still considered as fourth-line drugs because of their rebound hypertensive properties. Methyl dopa has hepatotoxicity and hemolytic anemia. So this treatment guidelines by JNC 8 guidelines, there are three strategies they have used. One is strategy A, start with one drug, titrate to the maximum dose and then add a second drug. Strategy B is start with one drug, then add a second drug before achieving maximum dose of the first drug. And strategy C is begin with two drugs at the same time as separate pills or a combination pills. Initial combination therapy is recommended if blood pressure is more than 20 upon 10 millimeters of mercury above the goal. So the bottom line is in all patients, first they started with lifestyle changes. Lifestyle changes including smoking cessation, control of blood glucose and lipids with diet, DASH diet, moderate alcohol consumption, reduced intake of sodium, and increasing physical activities, they are recommended in all groups. So if any patient, adult patient more than 18 years of age with hypertension, first implement lifestyle modification. Set a BP goal, initiate BP lowering medications based on this algorithm. If a general population, the patient is non-diabetic or CKD, if age is more than 60 years, BP target is less than 150. If more age is less than 60 years, BP target is less than 140. In patients with BP less than 140, they have divided into blacks and non-blacks. In non-black, start the patient with thiazide diuretics, ACE inhibitors, ARBs, or calcium channel blockers alone or in combination. In blacks with lower renin levels, start off with the thiazide diuretics or calcium channel blockers alone or a combination. After this, still a blood pressure goal is not met, reinforce lifestyle and adherence to drugs. Titrate the medication to maximum doses or consider adding another medications of another class like ACE inhibitors, ARBs, calcium channel blockers, or thiazide diuretics. If BP control is met, then continue treatment and monitor. Even after this blood pressure goal is not met, again, stress should be given upon reinforcement of lifestyle and adherence. Add a medication class which is not already selected. Hence, we can add a beta blocker, a aldosterone antagonist, and titrate above the max medication to the maximum. And if still blood pressure goals are not met, then again we have to reinforce on lifestyle and adherence. We titrate now to maximum doses, add another medications or refer to a hypertension specialist. So the initial drugs of choice for hypertension are ACE inhibitors, angiotensin receptor blockers, thiazide diuretics, and calcium channel blockers. Here you can see beta blockers are not the initial drug of choice. So there are certain emerging invasive therapies like carotid sinus stimulation or renal artery denervation.
Dr. Vishal,
Yes.
can you speak little close to the mic? The
Yes.
audibility is very poor.
Okay, sir. I'm audible now, sir.
Little bit in case, but are you speaking through a mic or how it is?
No, sir. Mic is not there, sir.
Okay. You have to be little close to the.
Based approaches for the treatment was and still is a patient with resistant hypertension. We have two systems in place here, the RIOS system and the newer generation of the NEOS system. RIOS H is a bilateral electrical field stimulation of the carotid sinus wall with electrodes placed around the carotid sinus rather than directly stimulating the carotid sinus nerve. The newer generation is the barotism, the NEOS system. It has got a unilateral carotid sinus stimulation with a smaller disc-shaped electrodes sutured to the carotid sinus, and this got an implantable generator which is made in the pocket of the anterior chest wall. These electrodes are connected to a generator. It allows it's externally controlled and allows controlled current delivery throughout the day and dose-dependent BP lowering. You can see in this diagram, this device delivers activation energy through the carotid leads. These leads conduct the activation energy to the carotid baroreceptors, and from there the baroreceptors send signal to the brain, sensing as raised blood pressure. Then brain sends signal to reduce blood pressure either to the vessels, the heart, and the kidneys. So we have two trials for this. One is the debut trial, device-based therapy in hypertension trial, which has got an endpoints of reduction in systolic blood pressure and safety at 3 months post-surgery. They included 45 patients in this study. As the years after treatment increases, there's a drop in blood pressure is sustained. So we can see after 4 years, the blood pressure drop is sustained and just approximately 53 millimeters of mercury. The other trial is the RIOS pivotal trial. It's a double-blinded randomized control trial. It showed a significant benefit regards to efficacy, but however, it did not meet the endpoint. For acute responders, most patients have developed facial nerve injuries. However, the trial was deemed equivocal and technology limited. So therapeutic efficacy is still continued to improve over time, as we can see in this graph. The device is on for 6 months. Device is on for 6 months and 12 months. So the renal artery denervation is another concept in which renal artery nerves in 1930 they have found the physiologists have found these pathological specimens. They found out that the renal nerves arborize around the renal artery. So this controlling this renal traffic helps in that it can modify the hypertension. So hence endovascular based radiofrequency catheter based approaches have been devised. So we have 3 trials for this: Simplicity HTN1, Simplicity HTN2, and Simplicity HTN3. The first and second trials, they were most done in the Europe. We can see the good pressure drop even in HTN2 trial, which is approximately 32 millimeters of mercury, controlled compared with a controlled group. However, this large drop of blood pressure, they found out that it might be a potential cure for hypertension forever. This leads to a lot of speculations. However, the Simplicity HTN trial 3 was conducted in the US. And they found out that there's no much reduction between patients with renal denervation or patients with control groups, which was 14.1 drop compared to 11.1 drop in patients with control group. Hence, it has ruled out the Simplicity HTN1 and HTN2 trials benefits. So if you can see this in this graph, most of the renal nerves, they are concentrated to the distal part of the renal artery. So the distance to the renal artery increases, so they are more concentrated towards the distal part of the renal artery. So this procedure altered to mandate the targeted distal therapy. Hence, targeting the more distal nerves has much benefit than targeting the middle or proximal nerves. So this is one of the catheter-based approach. This is spiral HTN clinical program. This Simplicity Flex catheter was an old one, which is obsolete now. And the Simplicity Spiral is the latest generation one. It has got a preformed flexible catheter with electrodes with 90-degree separation, and they are placed at different geographic locations. And the operator can on or off any of the electrodes. These are all 6-French compatible, 6-French sheath compatible devices, and the treatment time is only 60 seconds, and they can target a vessel diameter of 3 to 8 millimeters of mercury. So the trial which benefits of the spiral HTN trial, they found out that you can see in this graph, there's a consistent drop in blood pressure in those patients with spiral HTN rather than sham control, which they are going in hand with the baseline blood pressure. Hence, with this trial, we can find there's still the benefit even when the patient is monitored in the night time, morning, or throughout the day. there's still sustained drop in the mean period of 3 months. So this is ultrasound guided. From the radio frequency, we have come to the ultrasound machine. It's called the Paradise system, which is a rotational system. This is also a catheter-based approach. This got a balloon which inflates with the cooling system, cool water, which prevents the heat damage to the adjacent walls of the renal artery. And because of that, and it has got a high spinning filaments in this coil, which can penetrate to a depth of approximately 1 to 6 millimeters, 1 to 6 millimeters depth. So this is designed to achieve a target depth vessel ranging from 3 to 8 mm in diameter. So if you can see this in this picture, the 7 seconds on this, it works only, it's rapid, it's 7 seconds only. This is the balloon with a thermal gel model with a whole 360 degrees of the balloon. So along the length of the artery, first will give at the distal one will go towards proximal, and 2 insonations towards the proximal and 1 insonation towards the accessory renal artery. This is quick, but still they are not still approved by FDA, and still studies need to be done. This is alcohol mediated under system, which a site-specific delivery of alcohol, local nerve inactivation with no collateral damage. You can see this is also a catheter-based approach. It has got needles which penetrate in extracellular fluid, penetrates, and only 0.6 ml infuse it directly into the perivascular region. Extracellular fluid helps spread of this alcohol circumferentially in the perivascular space. Alcohol activity range is self-limited through the dilution by the extracellular fluid. Thank you.
Anyway.
So, Dr. Vishal,